Yeah, recording was started. And okay. So, Sophia, do you want after the 3 minutes to discuss a little bit how to approach the case, then you will do it, or you want to do it directly?
I think, I mean, I'm happy with anything. We can talk
No,
about how
it's
to do
up
it.
to you. It's up to you. If you feel that you want to go through it, that's fine. If you feel no, let's discuss what's my thoughts
No,
and how. Go
I
ahead.
think we'll go through it to do it in a
Okay,
better. Yeah.
as you like. That's fine. No problem at all. Okay, I'll give you the 3 minutes. You know, when you reach down, tell me to scroll it up so you can read down. Okay. Yeah.
Okay.
The 3 minutes is yours.
Can we scroll down, please?
Still, there is Doctor. If anyone can please admit the people in the lobby, that would be I will be very grateful, please. I still there is some wording down. Okay, to go down. You're happy with the ECG?
Yeah.
To go down.
Yes. Can you go up, please, a little bit? Okay.
Happy to start?
Yeah. Do you want to? I mean, I said like, can we discuss first how to approach the case?
Yeah, sure. As you like. So you tell me what's your thoughts?
Yeah.
What's
Okay.
your
So
thoughts
I
after
think I
now?
think when, yeah, I was reading it like, I mean, he's a male, 55 years old.
Yeah.
Um, and then you go ahead with um his Apple Watch is saying it's atrial flutter,
Mm-hmm.
and blood pressure
Yeah.
120/80, and then looking at the past medical history, I think it's a nice guideline. Even if the Apple Watch shows something, you kind of consider it.
Okay.
And diabetes, yeah, major issues like diabetes, hypertension. Yeah.
Yeah.
What is he taking? And then we
Yeah.
go down.
So actually, all this story from down till up is showing you that he having high cardiovascular risk. Yeah, this is
Yeah.
one. The other thing, his symptoms is more or less old, not new. Okay, so
Okay.
that's will differentiate. This is a new onset AF or atrial flutter, or all or old onset, which will having big difference in your management. Yes or no?
Mm.
Because you can see feeling heart racing on and off. Maybe was dismissed at that time because his blood pressure maybe was high and BMI was high, and they thought maybe it's caffeine, so they dismissed it. They didn't do ECG.
Mm.
That's questionable why they didn't do that. And then here Q risk is 9. Okay, also that's have some indication here. And then hemoglobin A1C is 50. And then they decided all of that saying that the kidney function is normal. Yeah, his kidneys are good, which mean
Mm.
that if you would like to start him in some medication, that will not affect the dosing. Okay, so this why this is here. And also if you want to do risk scoring, okay,
Mm.
also that means the risk scoring is not high. Okay, and then here's just saying that he's they start him in on amlodipine, which is calcium channel blocker. So usually calcium channel blocker will not be something that you will go for it, either rate limiting or non-rate limiting. More or less they have the same side effects. So that will give you a hint as well. And then that he's on, metformin, they refer him to the Desmond. Okay. And also that have an application here. Okay. So coming back to the first incidents where you said that, yeah, smartwatch, yes, smartwatch, and any, smart devices, because it's not only the watch. Okay, those your phone itself can sometimes record if you have arrhythmias or not. Okay,
Mm.
and there is now there is now portable ECGs as well. There is portable ECG devices. Okay,
Mm.
not that accurate, but you can use them. There are 3 leads, so it's not 12 leads. That the definite diagnosis is the 12 leads ECG or the Holter. So if 3 leads, it's questionable. So still, you can pay in the pocket. By the way, you can, if you are going to home visit or something, you can buy some. Some of these devices will help you. So
Mm.
if it's not 12 ECG, yeah, it will raise the suspicion, but it's not enough for diagnosis. Okay. However, they
Okay.
give you 12 lead ECG. Yeah. So there is
Yeah.
diagnosis. Yeah, is it flutter? Is it AF? To be honest, at the level of the GP, it doesn't make a big difference because both of them will be treated the same. Okay.
Yeah.
The only difference is
It looks
that,
kind of both. I don't know.
yeah, well, you are right. Well,
Sawtooth wave
this is,
and
yeah, there is a category. This is called flutter with variable grade, with variable block. Okay, we'll discuss it, but this, I don't think it's important at the GP level, but it's important for you to know in the future. Okay,
mm.
as a GP, but not for the exam level. Okay, yeah, there is something called flutter with variable blocks or fibrillar flutter. Okay, which is a flutter, basically flutter. We can see the flutter waves here. Okay, the flutter waves. Okay,
Yeah.
but actually is not regular. Okay, so in general, any irregular rhythm, consider in your exam, any irregular rhythm, consider it, as AF till proof otherwise. Okay, um, and then if you, so why the Q risk that they say down 9, and then why it will be relevant in this case? Do you know?
Q risk.
Mm. Can see the Q risk before the diagnosis. Yeah, what is your Q
Yeah.
risk? Yeah, was 9. So if this is a patient having a flutter, would this make any change for you?
I think Q risk at high, isn't it?
Yeah, 9 is still low.
No, it
Yeah,
gets high, I think.
yeah, it gets higher. Why?
Not sure.
Yeah, I will explain that. So QRISK 3 is containing AF, okay,
Okay.
as one of the categories. Yeah, unfortunately, in the system one, still we have QRISK 2, which is not considered AF as one of the risk factor, but QRISK 3 is considering AF as a risk factor. And hence, when you put this in consideration, most probably his QRISK will increase. Would you need
Okay.
to do any modification in his medication? You
Will we
might,
initiate
you,
statins or
yeah,
talk about it?
this is one, and there's another one, another thing.
In his medication.
You might in the management tell him we need to do some modification in your medication when you, if you would like to bring him in. You might not have enough time, okay, to discuss all the medication that you need to change it, but just to mention it in the management, that will give you the mark. But also that's important in your real life, okay? So if that patient have high risk increase, yeah, he will be indicated for a statin. But another thing also, you need to change.
Okay.
What the other thing that you need to change?
In his
And
medication?
which is important and that's coming as a sole case in the exam.
Not
That's
sure.
why I put it just to reinforce the information and how we can apply it in the real life. So
Okay.
if a patient having diabetes and above 40 and has Q risk above 10, what is the medication? What usually that medication that you need to put him on?
Bramipril.
Um,
He is in
dapagliflozin.
Ramipril. Yeah, dapagliflozin. Excellent.
Dapagliflozin.
Who said dapagliflozin? Sophia? You?
Yes. Yeah.
Oh yeah, dapagliflozin. So the first line. So for now in diabetes, it's not now to be honest. It's this all it's for like 2 years now. Since they changed the guidance. So the first line of you can have monotherapy or dual therapy. So if the patient is low risk, Q risk is low, we'll give him metformin, okay, as the first line treatment. But if he have, the new onset diabetes or diabetes type 2 and his Q risk above 10 and above 40 years old, then you need to start him start him on dual therapy. Yeah, and according to the guidance, you will start say metformin, and then you will reach the maximum tolerated dose, and then you will add the dapagliflozin 10 milligram. Okay, so here this patient would, when you recalculate his Q risk, you would put him on the dapagliflozin.
Okay.
Okay, so these are all extra layers of difficulties. Most probably, if appear in the exam, usually it will appear as a solved case because there will be no time to discuss all of that.
Okay.
But I bring this case only to try to connect the topics together and reinforce some of the information. Okay,
Okay.
so are you happy to go through it?
Yes, I'm happy to start it. Can we? Can you go down a little bit in the other
Yeah, sure,
information?
sure, sure.
Okay, that's fine.
Sure.
Yeah.
Okay, so let's open his name. Okay, go ahead.
Hi, I'm Dr. Sophia, one of the GPs at Park Practice. Is that Jack English?
Yes, doctor, thank you for calling.
Hi, Jack. How can I help today, Jack?
Well, doctor, I came in the morning to the nurse because I have been, struggling with my when I'm going to the gym, especially when I'm on the treadmill. I don't know. I feel more shortness of breath, to be honest, and I was complaining of this for a long time, and recently I read this article about the smartwatch and how the smartwatch can help if to detect any problem in our heart, and then it seems to be when I'm running, is giving me a warning of actual flutter, I think, or fibrillation. I'm not sure which one of them. The nurse did some blood test, I think, in the morning to me, and she did an tracing to my heart, and then she told me the GP will call me. So I'm not sure if there's anything there, doctor, or something.
Right, Jack. Thank you for explaining that. Yes, I've got the ECG here with me. Would you like me to go first through the ECG, or shall I just ask a few questions to explain you in a better way?
Well, as you like, doctor. As you like.
Right. Okay. Okay. So I mean, you told me like you have since last few months you have been noticing that you're getting short of breath when exercise, and now your smartwatch has detected some irregular heartbeat. Um, have you experienced anything else, any other symptoms along with it?
Like what, doctor?
So I mean, like, have you noticed any chest pain along with it?
No,
Right. Have you ever felt dizzy?
no,
Right. Okay. And have you ever had like loss of consciousness, or have you ever fallen?
no.
Right. Okay. So, and you have noticed this on exercise, but have you noticed it at any other time, like when you're resting or at home?
No, mostly during exercise. Maybe when I was driving once, maybe.
Okay. Okay. And then how long usually it lasts for when it happens?
It varies, to be honest, doctor. So when I exercise, maybe it will stay 1 hour after exercise. But when I was driving, it happened only once and stay
Right.
only
Okay.
5 minutes. I needed to pull over and to calm down.
Okay. Okay. Right. Okay. And I mean, like, what did you mentioned like when you were driving, it lasted for 5 minutes, right?
Yeah, yeah.
Okay. So, I mean, the thing is, Jack, irregular heartbeat can be because of multiple reasons. So, I'm just going to ask you a few more specific questions. So sometimes, like, thyroid is a gland in our neck. When there is a problem with that, it can cause irregular heartbeat. So, have you been having any feeling of being hot when others are feeling cold?
No, doctor.
Right. Okay. And have you noticed any weight loss at all?
Well, I lost some weight, but intentionally. I'm doing that intentionally. Yeah, I'm
Right.
doing
Okay.
exercise, yeah, for my diabetes.
Right. Okay. Okay. And have you had any recent infection?
Yeah, not I'm aware of.
Right. Any cough or cold?
No,
Right. Okay. Okay. And sometimes if you have an irregular heartbeat, um, it can cause symptoms like weakness in your arms or legs. Has it ever been the case with you?
no,
Right. Okay. Any tingling on half side of the body? Any headaches?
no,
Right. Okay. And have you noticed any swelling of your feet at all?
no, doctor.
Okay. Okay. Okay, I'm sorry for all these questions, but these
No, no.
questions are important. Um, right. So you told me that you've been doing exercise for diabetes. So well done. That's really good to know.
Thanks.
And I can see you are on different medications as well. Have you been taking that for diabetes and hypertension?
Yes, doctor.
Right. Okay. Sometimes there are a few things in a lifestyle which can affect how we are feeling, what symptoms we are experiencing. So, um, may I know like how much do you drink?
Drink. You mean alcohol?
Yeah.
Well, not much, doctor. To be honest, occasionally I will drink. It's not unusual basis. Maybe once every week. And over the weekend I will take a couple of pint of beer.
Right. Okay. And when you say like a couple of pints over the weekend, what exactly do you mean by that, Jack?
So to be honest, it's only I will take one can of beer. That's only. So I'm not a fan of beer, to be honest. So
Okay.
only
And you
only can of beer over the
right.
weekend.
Okay. And apart from beer, do you drink anything else?
No, doctor, no. Maybe coffee. Yeah, I'm drinking coffee, but your colleague told me to drink, to decrease the amount of coffee I'm drinking. So I managed to drink from 5 cups. Now it's 1 cup a day.
Right. Okay. And did it make any difference to your symptoms?
Yeah, yeah. To be honest, I the palpit, the heart racing frequency decreased. I'm not getting it that much in rest. It was,
Mhm.
before that I was having it even in rest, but now it's not only in
Right. Okay.
exercise.
That's good, isn't it?
Yeah.
That's very good. And have you been stressed at all, Jack?
No.
Right. Okay. And may I know what do you do for a living, Jack?
Uh, well, now I'm in retirement, doctor. So I have a taxi company, okay, back in London. Now I'm bringing people to work for me. Rarely I will go on the drive if I have a shortage of staff. That's only.
Really?
Yeah,
Right.
very, very
Okay.
rarely. Maybe once every 2 months or something.
Right. Okay. Okay. Okay, Jack. Thank you for all the information. I know you mentioned like because your watch was saying it was an irregular heartbeat. Um, did you have any other idea or thoughts what it could be?
No, to be honest, I don't know.
Right. Okay. Okay. And then, are you worried about this at all?
Well, yes, doctor, to be honest, because my grandfather, he had problem in the heart, and I think he have like AF, and he was in warfarin,
Hmm.
and unfortunately had, bleed in the brain because of the warfarin.
Hmm. Sorry to hear about him. Oh,
Yeah, that
okay.
was long time ago, doctor.
So, is this something that makes you worried about this?
Well, yeah, to be honest, if I don't, if you will put, if this is something related to my heart and you want to put me in blood thinners or something, I will be, worried about that, to be honest.
Okay. Okay. Thank you for sharing that. And obviously, we'll discuss whatever is best for you today. Was there anything in particular you were hoping, Jack?
No, just, if we, I just want to do my exercise without feeling weird, okay, and without being exhausted because of that.
Okay. Okay, Jack. We'll see what we can do about this. Okay, Jack. So for thank you for all the information which you have given. Um, I've reviewed the ECG as well. So from what you have told me and looking at the ECG, it looks like you're suffering from a condition called atrial fibrillation, like you said. Um, how much do you know about it, Jack?
Well, to be honest, not much. It's just my experience with it is like from my grandfather. I told you that he had this bleed and he did because he had some, give him blood thinners. That's
Mhm.
only. I'm not sure, you know.
Right. Okay. Okay. So let me explain it for you. So this is a condition in which different parts of the heart are beating in an unsynchronized way. Um, and then it leads to symptoms like heart racing, breathlessness. Um, I mean, like there are different ways we can treat this condition. There are few lifestyle modifications which you have already done. You have cut down intake of coffee, so well done for that. And then I know you're drinking alcohol, one can of beer just over the weekend. Sometimes alcohol can trigger this, but you're not. I mean, like one can of beer is fine, but if you can even cut that down,
I
that
will
will be
do,
great.
doctor. Yeah, I will do. I told you I'm not fan of it. I will stop it without doubt. Yeah.
Okay. Okay, right. So the way we treat, I think it's really important, Jack, that I bring you in, examine you, listen to your heart as well. It's important, like how fast your heart is beating. um, the way we treat atrial fibrillation is we have to control the heart rate, and also we have to I know you mentioned you're worried about about the blood thinners because your grandfather had bad experience with them, but just want to reassure you there are new blood thinners in the market, um, which has like lower risk of bleeding as compared to warfarin.
Okay. Okay.
Yeah.
Yeah. Well,
And I know yeah, sorry.
yeah, that's fine. I mean, if you are saying that there is a new medication and the bleeding risk is less, well, so do you think I will need the blood thinners?
Yes, it does look like, Jack, because there is usually like a medical calculator which we call as Chadwa score. So we put your details into that calculator. But looking at your history, it looks like it's going to be high. And if it's more than one in your case, we kind of will start you on blood thinners.
Sure,
So
doctor. Yeah.
Okay, and the other thing is, as I mentioned, like if your heart is beating fast, then we have to start you on a on something which is we called as beta blocker, or because they control your heart rate and kind of lower down your heart rate.
Okay, sure, sure, doctor. Um, it's just because I read, doctor, that you can refer me to the heart doctor where he can restore my heart, something like that. So
Yes. Yeah.
is
So
that
it is a yeah.
uh,
Sorry.
is that an option? And if they did that, would that will I still need to have this blood thinners?
Yeah. Okay. I mean that's usually an option if you come within 48 hours of starting having the episode. Time is finished.
No, it's fine. No, no, it's okay. By the way, you did it very good. No, continue. It's okay. So what do
Okay.
you think? How you will answer this obstacle? It
Okay.
won't be like that in the exam. Okay, this obstacle is just to increase the knowledge. So how you will answer him?
Okay, so yes, there is a procedure which we called as cardioversion. It is usually done if when the patient present within first 48 hours of having an episode. Um, but there, so once the rhythm goes back to normal, in some people it can go back to like AF. It can go back to an abnormal rhythm again, and if that happens, they are still at high risk of having clot. So it is important for you to take your blood thinners even after cardioversion.
Okay, good. Yeah, that's right. But also cardioversion is not only after 48 hours, is it? Or before 48 hours. Sometimes, the rate control and the rhythm control can be extended after 48 hours. Yeah. You can give him the anticoagulation for 3 weeks and then referring him meanwhile to the cardiology so they can cardiovert him, either chemical cardioversion, although chemical cardioversion will be in the first 48 hours, they will do electrical cardioversion. But still, even, and this is the thing that we need all to learn from today, that even still after, the cardioversion, this doesn't mean that they will not take blood thinners. Okay. They still need to have the blood thinners because the rate of recurrence is high and then they can have a stroke. Okay. So if the patient think that if cardioversion happen and that will prevent him from using the anticoagulation, that's not right. Yeah, well done. To be honest, what's
Okay.
your reflection? Big,
Yeah, I don't know.
big improvement. Okay, I'm happy with. Well, no, no, really, I'm happy. Yeah, I was not expecting. No,
But
that's
I think
good.
time management was not good, but I think it's, I don't know, sometimes it gets hard to manage time.
No, well, no, I think your management. I mean, I think your management is fine, to be honest, because
But
you
then
you did.
statin and metformin and I don't that's statin
Well,
and
well,
dopamine.
yeah,
So
well, we said it will not. It's difficult to be that, all this complex layer of complexity is difficult. Okay, but you might might tell him when you come, we'll discuss also some modification of your medication, and we need to recalculate your Q risk, and then most probably they explained for him what's Q risk, and then when they calculate it hopefully. So he know what his Q risk is. And then we said we need to recalculate your Q risk, which give us, your risk in having a stroke in the 10 years time. And then you might consider you adding in a statin. Um, Keeping in mind, mostly this patient will resist the statin because the statin, as we said the last time, is increasing the incidence of having intracranial bleed, especially if you are putting it with the anticoagulation. So obviously he's reading a lot and he knows what he's talking about. What else you think you would add, and it's important, and I put it also as a trick and the case scenario in between. What
I
you
mean,
think?
like, what will you say to the patient?
No, no, something you need to add in the management plan. I put it in between as a trick. What's his occupation?
Yeah, I think I wanted to say to him, maybe I think he should stop because he's really
Mm,
driving taxi. So we'll
yeah.
We'll ask him to stop
Yeah,
for
yeah.
some time until he gets better.
Yeah, well, it's not only that. Driving in general, you need to get. Especially, he told you that I had the symptoms while I'm driving once or twice. So then we need to control first the symptoms, and if he's license one, then 4 weeks. If license two, 3 months. So that's important.
It,
With
so group one is for four. They need to avoid driving
four
for four
weeks,
weeks of,
yeah, 4 weeks until you control the symptoms.
and
If the
then 3 months for
symptoms,
group two.
yeah, the taxi driver is 3 months. Okay.
Okay.
The other thing that also, yeah, why you want to bring him in? Because that's also important.
I think we need to listen, like if there is any murmur, or
Yeah,
listen to the
why?
heart,
That's right. Why?
and also like to check for like blood pressure and things to
Yeah,
check
yeah.
for hemodynamic
What?
instability.
Yeah, this will discuss it now. But I need to know why you need to hear his heart to see if there's murmur or not.
If there is
I mean, yeah,
there
sorry,
is any heart abnormality, valvular heart disease,
Yeah, which means
warfarin.
is it
warfarin.
if yeah,
Yes. Yeah,
yeah,
warfarin. Yeah, yeah. That's
okay,
important. Yeah, so valvular and ever and it's enough to listen, okay? So you don't need to send the patient to do echo, okay, to exclude valvular and non-valvular heart disease, because when they said valvular heart disease, they mean moderate to severe. So if you didn't listen, unless you have problem in the listening, okay? So take care of that. If you don't know how to listen to the heart, and you need to learn how to listen to the heart, okay? So if he doesn't have, if you have moderate to severe valvular heart disease, then it's indicated for warfarin. If it's very mild, okay, then it's fine. And also not every valve, okay? So it's only the mitral valve. So the patient have mitral valve
mitral
disease,
valve. Yeah.
yeah, then this is the valvular heart disease. Or if they have mechanical valve, sure, if you have mechanical valve, usually he will be on warfarin without even having AF. Yeah, that's good. So let's take it from the start. So your opening statement was fine. It's just you forgot and you said, "How can I help you?" And you said, "Please use the pre-existing information." So I waste your time around 1 or 2 minutes just telling you a story that is already there. So you might, so don't forget, use the pre-existing information. Okay. And when you ask open question, don't make it too open. Any other symptoms, you need to specify, okay? Don't say only other symptoms. And to be honest, for me, if I'm doing the case, so cases of chest pain, cases of AF, cases of bleed, before going through, after I, introduce myself, double checking the name, before going through my questioning, I would say I will start, to check the safety of the patient. You'll say, yeah, I can see you are worried about, your heart, or you are worried about these symptoms, but then before going to further questioning, just can I double check, do you have any chest pain now? Do you have any shortness of breath? Just I want to make sure that you are safe now to continue the consultation. And if he told you, yes, I'm fine, then complete your questioning. Okay, rather than start to question. That's the first step when you are managing a patient with AF. You are thinking, is this patient is for me as a GP or for the emergency department? So if the patient is stable or not. And the signs of stability, as you said. So what is the signs of stability, Sophia?
Yeah, so I mean, like if pulse is okay, blood pressure is fine, and patient is a
Yeah, and that's what's
hemodynamic
given, is
unstable.
it? Yeah, so they give you the blood pressure and then they give you the pulse. That will give us another then question, how you will calculate the pulse from here. Because I didn't give the pulse here. Usually, please, in real life, don't depend on the blood pressure machine or the pulse oximeter if the patient have AF. It will give you wrong reading, okay? If you either you calculate it by your hand, feel the pulse, or listen to the heart and calculate the pulse from the, bicentral pulses, or from the ECG. So how you will calculate the pulse? You know how you calculate the heart rate from the ECG?
I can't remember. I think it's like number of R waves in 6 seconds multiplied by 10, or I can't.
Yeah, then how we will calculate 6 seconds here?
That's hard.
Yeah, and in the exam you will not be able to calculate. Yeah, how you will calculate 30 boxes? Is it 30 boxes? I think it's 6 seconds. So there is a standard, okay? The one ECG, so the one block of the ECG rhythm strip is 10 seconds, okay? So these are 10 seconds, okay? So all the ECG, the four, which containing 1, 2, 3, 4. So four leads. So every 4 leads is 10 seconds. Okay. So in these 10 seconds you can calculate the number of the R waves and multiply it by 6. So to have 1 minute. So you
What is
just
10 seconds? Sorry, the whole ECG
so
is 10
yeah,
seconds.
not the whole ECG. The whole rhythm strip. Yeah. So the strip here, all are 10 seconds. So from lead 1 till V4, this is a 10 second.
Okay.
Okay. So 10 seconds, if you multiply 10 by 6 is 60. Yes. 60 second is a minute. Okay. So you need the pulse in a minute, isn't it? So you will calculate the number of the R wave in the 10 second and multiply it by 6 will give you the pulse in a minute. Is that clear or what?
Yeah, so if you look at lead 3 and there are like 1, 2, 3, 4, 5, 6, 7, 8.
Mm,
Yeah.
So lead 2 you mean? So the long lead, usually long lead 2, yeah?
Yeah, so it's
Lead 2,
15 hour wave. So
even,
do we multiply 15 with 6?
yeah. So how much would be like 90 or something like that, isn't it?
90,
Yeah.
I
So
think.
so still less than 110. So 110 is to treat or not to treat, but 150, yes, is stable or not stable. So if the heart rate is more than 150, okay,
That's hospitalized, isn't it?
yeah, that's fast. Yeah, so that's fast AF, and then we need to refer him to the emergency department. Yeah, and then the symptoms, as you say, the blood pressure, any chest pain, what else? Syncope. Yeah, what else?
Syncope. Yeah.
Yeah, leg edema. Yes, leg swelling. Yeah.
Yes, heart failure. Yeah.
So then after what you did, so after you make sure that the patient doesn't have any symptoms of instabilities, okay, then you will search for the cause, isn't it? This is the second step. When you did it, to be honest, you did it. Maybe you didn't ask everything, but you did ask about, thyroid, you did ask about weight loss, okay. But don't forget when you are saying weight loss, you mention is it intentional or non-intentionally, okay. And then infection, because I could trick you here. Yeah, I'm losing my weight, okay. And actually, I'm intending to lose weight by exercise. And then you ask about weakness of the leg and swelling of the feet, which is complication. But what else you need to ask also here, which is important, other than the infection? I'm always, you can pick 1 or 2, 3 maximum causes, ask about them, just, for the examiner to know that you are asking about the causes. But what else is important to be asked about? And you don't need to forget it because it can be life-threatening. One of the causes, other than cancer, because you ask about cancer, ask about thyroid. What else is important?
With atrial fibrillation.
Hmm.
Do we ask about family history or
No, it's
any
one
person?
of the symptoms, one of the things that you should not you should not miss as a cause of AF.
Is it a sudden death in the family, HOCM?
Well, sudden death in the family, we usually a patient will come with syncope and with no, yeah, it will not be AF because we are looking then in conduction abnormality usually.
Is it PE?
Not if, yeah, PE, yeah, PE, yeah. So they usually ask about, especially his driver, isn't it? We don't know if he drive for long distance recently or not, although he said he's retired. But then don't forget asking about calf tenderness and calf swelling. Okay, is it okay?
Yes, yes.
Yes. Um, and then you ask about psychosocial eyes. You ask about drinking. It's just when you relate the psychosocial, you said I will ask which can, you know, a little bit about, I'm not sure, a little bit about your social history, which can affect our life, isn't it? Or our health. Yeah.
Yeah, the
Well,
symptoms you're having, I said. Yeah.
yeah, which, you know, which little bit formulaic, okay? So you ask him directly, okay, you know, drinking alcohol, you know, can affect your, you know, can affect the AF, can produce the AF itself. So I'm just wondering how much alcohol you are drinking, okay? And say alcohol drinking, because when you said how much you drink, I'm not sure what you are asking about, what type of drink you are asking, okay? So alcohol drinking, okay? And then coffee
Okay.
and stress, you can relate it easily. To be honest, you shouldn't struggle here for the psychosocial. You can relate it easily, okay, to the AF, because most of the psychosocial will be related to the AF. Stress can cause, AF can cause even myocardial infarction, so that's related. Okay, coffee, alcohol, smoking. I'm not sure you ask about smoking or not. I can't remember, to be honest.
I don't
I
think so.
didn't hear you. Yeah, I didn't hear you asking about smoking. And don't forget illicit drug, because here it's really relevant. Okay. Yes, he's 55, but illicit drug is very relevant to AF. Okay, or flutter. And then the driving and management. Yeah, to be honest, management, I like the way that you explain AF. You said that one, you know, the parts of our body are not, you know, beating or yeah,
Yeah, I
beating
said the parts.
synchronizing. Yeah,
Yeah, the parts of the
unsynchronized. Yeah,
yeah,
go ahead.
unsynchronized way.
Yeah,
Yeah, I just
unsynchronized.
said like when the parts of heart are beating in an unsynchronized way. Yeah.
Yeah, well, which very simple. But I know for me, when I'm thinking you have irregular heartbeat. Okay, the patient knows what's irregular heartbeat. You have irregular heartbeat, and that causes your symptoms. If you will use unsynchronized, that's fine. Okay, but maybe if it's simple. What you said is very simple, and I like it. Okay, rather than saying okay, you have say no, then they say, because a lot of people is doing that and wasting their time. You don't need to massively explain to the patient what is SA, what is AF. Just irregular heartbeat or unsynchronized heartbeat, which cause your symptoms. Full stop. Okay. You may give further explanation what are the symptoms, why he have shortness of breath, you know, so that your heart will pump the blood but ineffectively, okay, as well as as well as that will make also the heart, the pumping, the flow, the blood to stagnate little bit in your heart and make clots in the lung and the heart, and then one of these clots can cause you a stroke, or go out of the heart and make you stroke. Just to make sense why you need to give him the anticoagulation. Okay, you might add these two bits, so you will make sense of why you need to put the anticoagulation, and the other things why you might need to give him beta blocker. So what's your choices, Sophia? So are you convinced by adding these two extra piece of information about, the why he's having shortness of breath and why he will need to add that the anticoagulation to the explanation?
Yeah, for the
Yeah.
anticoagulation, you said explain about stroke risk and for breathlessness.
Yeah, well, yeah, but related to the yeah, with you, but related to the irregular heartbeat. So he will know, he will understand why you need to put him. Okay,
Okay.
plus making the the stroke risk, because most probably most of the patient that you will meet in your life, that with the stroke risk will be high. Okay, and basically you don't need to try to calculate it in the exam, because you forget about the sex of the patient. Okay, forget about it. But okay, but any patient having any cardiovascular risk, he will be indicated to to start an anticoagulation. Okay, because if you look at the CHA2DS2-VASc score, all of this is anticoagulation. All of the risk factor are cardiovascular risk, and he's hypertensive. Okay, so that's one, and he's male, so he's more than one. He will be indicated. So make it easy. In the exam, if the patient have cardiovascular risk, then his CHA2DS2-VASc score is indicated for anticoagulation. Okay, and diabetes, this is the other risk. And then the orbit score already, I think they give you I will answer you, Ayo, but just to finish the rest of the comment on, I will answer you. Don't worry. Okay, and then just to see, you can see that also the orbit score most probably will be fine. But my question here to you, Sophia, if the patient have high orbit score, what you will do?
I think we'll just explain to the patient
What
what
you
he
will
would like.
explain? So say my orbit score now is 2. What you will explain to me?
So, for instance, if your adverse score is higher, higher than 2, so we can say that your risk of having a stroke is um, higher than your risk of having a bleeding.
Yeah,
Can we
so
say
the
something like
benefit,
that?
yeah, you can say, you
Outweighs the
could say
risk.
the, yeah, is a, yeah, you say the benefit of
Yeah.
having, the benefit of having the anticoagulation and preventing the stroke is outweighing the risk of the bleeding. Okay, you can't say something like, and what is the, and when you are explaining to him the new anticoagulation, we have, as the warfarin, you have the antidote. So if he start to have a bleed at any time, please, this is one of the safety netting that you need to say. If you start
If
to
you
have
never
a
had
bleed or
injury, yeah.
yeah, if you have any bleed, if you have any problem, you need to come. Not head injury per se, but you need to tell him, yeah, for sure. If you had any trauma to the head or any head injury, you need to come and let us see you, because some of the doctors are avoiding to put the patient on anticoagulation if he have a high risk of fall, which is not right. Okay, even when I was in my hospital rotation, the frailty consultants usually was avoiding putting the patient on the anticoagulation when the patient have high risk of fall. But nice guidance is saying that's not right, because again, the high, the risk of bleeding after a fall is not that marked. Okay.
So I think I've
Um,
been told like they're nice. They are now saying not to consider like not to do an orbit score when starting anticoagulation. It's I don't know. It's a very
No,
recent thing.
according my reading, no. Maybe you
Okay.
are you maybe you are you maybe you are telling about has blood score.
I think I went to like NB Hot Topics. It was just this month, and they said like
Mhm.
they're going to remove the orbit score. So I'm not sure
Well,
whether it's
well,
removed.
well, well, even if they remove it, we need to know what is the importance of the orbit score. So the orbit score or even has blood score from before was not made to say that you will start the patient on anticoagulation or not. Okay. Is just to emphasize that the patient might have some modifiable risk factor of bleeding that you need, to try to control it. Okay. For example, if this patient have, microcytic hypochromic anemia or have anemia, so this means that he's bleeding from somewhere. Yes. So you need to search where he's bleeding from and try to, to stop the source of bleeding. And that's why the patient will have less risk of bleeding. For
Yeah.
example, this patient have anemia of 110, and then when you start to search the cause of anemia, he had a gastric ulcer. So you might consider putting him PPI. You might consider, seeing what might cause the gastric ulcer. Yes, is he taking non-steroidal? All of these are tricks can be combined in these cases. Okay, they can give you a patient having non-steroidal, patient on selective serotonin inhibitor. So you need to modify his medication in a way that when you add the anticoagulation, that will not increase his risk of bleeding. So, for example, he's taking SSRI because he's, having depression or anxiety. He's taking the SSRI for 5 years. So this is indication now to try to withdraw the SSRI. Yes. So usually more than 5 years, it's advisable to start to remove the antidepressant from the patient. So you will tell him, okay, we might consider, sending you to talking therapy or gradually withdraw the SSRI. Okay, so we can put you on the anticoagulation safely. Okay, if he's taking non-steroidal, for example, naproxen or ibuprofen because of hand osteoarthritis or knee osteoarthritis, then you might consider adding for him or removing the non-steroidal and adding a non-steroidal tablet and putting him on a cream or putting him on cocodamol. So this is the importance of the orbit score, not to say that if the patient have high orbit score, you will not start him in anticoagulation. No,
Okay.
because even if the patient have high risk of bleed, again, the anticoagulation is more benefit is outweigh of the risk of bleeding for most of the cases. Okay.
Yeah, thank you.
So beta blocker. No, wait a minute. Still, there's another risk, another adding of layer of complexity, because that question, a lot of people started to ask me recently about it. So you like to start on beta blocker, isn't it?
Yeah.
Okay, that's good. Yeah. So if the patient having asthma, what you will start on? Because I can make that patient have asthma. So what you
Yeah.
would like to start on?
Diltiazem or verapamil.
Okay, good. If this patient have the bisoprolol 10 milligram for his blood pressure, what you will start him on? Yeah, so because that patient have ramipril, yes, for his
Yeah.
yeah. So if this patient have bisoprolol 10 milligram and he's still having AF, what you will do?
Can we change it to ramipril and start bisoprolol and lower down the dose of bisoprolol?
But well, he's no, I didn't get it.
Sorry, I mean,
I
like,
didn't get it.
can you put him on another medication for blood pressure, and you lower down the dose of
Can
bisoprolol?
you use nifedipine?
Nifedipine, well, nifedipine is non-rate limiting, isn't it? You
No.
mean nifedipine for, but you didn't get, I think both of you, or I was not clear in the question. So if this patient have bisoprolol, but it's 10 milligram, and still he is getting AF, isn't it? So he already taking bisoprolol for blood pressure, for example, but still he's getting AF on it. So what will be your next step?
Can you use
Is that
reductant?
clearer?
Yeah.
Is my question clearer like that? So what you need to do next?
Digoxin, refer for digoxin.
Well,
Put up a mute
digoxin, that's good. That will take us to another question. When we need to use digoxin, do you think this patient? Well, the patient told you I'm getting the symptoms on the treadmill. So what is the indication of digoxin in AF? That's good. That's good. I like the discussion now. The things are becoming more difficult.
Digoxin is only used for those who have sedentary life, not for active patient, I believe.
Good. Yeah, that's why. Do you know why?
Not sure. I can't remember why, but I know only for except for sedentary
Yeah.
people,
So
not everyone.
yeah, exactly. So let's then discuss how the digoxin is working. So the digoxin is acting in the AV node as vagolytic, isn't it? So when you are running and the AF is induced or the AF is increased, do you think is the vagus nerve is the responsible one, or the sympathetic system responsible for exacerbating your AF symptoms?
I guess sympathetic nerve because I'm running.
Sympathetic. So
Sympathetic.
that's why you cannot use digoxin, because digoxin usually will control the AF for the people who live sedentary life, because this is the
Okay.
vagus nerve is the responsible on it. It
Okay.
doesn't act on the sympathetic nervous system, and that's why the guidance is saying, okay, digoxin you can try it, but the people having sedentary life, okay, because of that reason, okay, because digoxin is acting on the SA node through the vagus nerve. So digoxin is out of the game here. So what will be the next step? Because I heard
Yeah,
someone said let's.
amiodarone.
Well, amiodarone, yeah. Well, amiodarone is
I guess
amiodarone.
it's a
Yeah.
secondary care amiodarone, isn't it? Prescription.
No. You can no. Well, well, you still
Bleeding
can
control.
use the amiodarone, but amiodarone you can use it only in short term, and I don't think most of the GP will have experience with it, and it's
Yeah.
actually a nasty drug. Okay, so and amiodarone is used in in two ways. Okay, so amiodarone can be used on as rate control and as rhythm control, which is dose dependent response. Okay, So the only time that I'm using the amiodarone is not in the GP land. Usually when I am in the ED, okay, or in the ITU, yeah, and the patient is unstable, I will give him some amiodarone. I'll try to control his heart rate, okay, before even the DC, because sometimes we're giving it to facilitate the DC. I don't advise using amiodarone in the GP land. It's a very
Can you
nasty drug,
use
and the long
these anti-arrhythmic drugs? I've forgotten their name now.
procainamide.
Yeah, the anti-arrhythmic. I don't know your campaign in primary care. I think it's hospital.
Yeah, again, most of most of them are rhythm control, not rate control. So if the patient on be already in beta blocker, you still can use.
Mm.
So if the patient on bisoprolol, you still can use verapamil or diltiazem to control his AF symptoms. You can, but not by you, okay? Because it's, you can induce heart failure for these patients. You can just send advice and guys or refer him to the cardiology and tell him he's already on maximum dose bisoprolol and his symptoms is not controlled, his AF is not controlled. So then he might add for him verapamil or diltiazem. Yes, Sophia.
I forgot my question now. I will ask you in a minute.
Yeah, no problem. Because Ayo wanted to ask something, and I told her, wait a minute. So Ayo, what's your question?
Yes, thank you for the session, family. I was just
No,
going to
no
ask
problem.
about the beta blocker. So at what heart rate would you say would
Yeah,
start?
well, good question, because according to NICE, if it's more than 110, but or if the patient symptomatic, okay, so even if less than 110 and the patient is getting symptoms, so you can start him in any of the beta blocker, okay. Usually, what I learned when I was doing, because I have, preventive cardiology diploma. So usually what we will do, we will first is control his, resting heart rate. So we'll see the resting heart rate. If it's more than 110, then we will give the beta blocker, okay, to control the symptom. And then we will target his exercise heart rate. So if his exercise heart rate is reaching 140, 150, or reaching the maximum tolerable heart rate, which is 220 minus his age, then I will consider adding also, beta blocker just to reach the exercising heart rate within his capabilities. Um, for us as a GP, it's 110. Okay, less than 110, don't start beta blocker. Okay, except if the patient symptomatic. Yes, Sophie?
Yeah, so you mentioned like listening to the heart sounds is enough and there is no need
Yeah,
for echo.
yeah.
When we if we diagnose like atrial fibrillation in GP and start them on bisoprolol and anticoagulant, so they don't need to see cardiology at all, or do they still need echo kind of to confirm?
No, the referral will be have certain limits. Okay, so the referral, if the patient, not every AF you will refer him to cardiology. For sure not. Okay, so if the symptoms are not controlled, okay, you would refer him. Okay, or if you are suspecting the patient have underlying cardiovascular problems or underlying structural heart disease, then you will do the echo. Okay, or if the patient have very high orbit score, okay, then you will do the echo. Other than that, no need for referral. Okay,
Okay.
except like that case, if he's in beta blocker and then you want to start, because yeah, it's written in the guidance, you cannot put beta blocker on with the rate limiting calcium channel blockers
Oh,
within limits. Okay, this information is right within limits. If it's still patient having symptoms of AF, you can add for him verapamil or diltiazem with the beta blocker. So if you find that, for sure not put by the GP, okay, not at the level of the GP. This is at the level of the cardiology. So if your patient come to you from the cardiology and then with beta blocker and calcium channel blocker, okay, rate limiting, and he's telling you that, for example, the pharmacist refused to give me the treatment because he's worried, and then he's coming to complain and say this cardiology want to harm me, or you need to explain to the patient, no, I will double check with the cardiology doctor, because sometimes we can use the beta blockers, okay, with the rate limiting calcium channel blocker, especially if he is symptomatic, okay? Is that clear, doctor?
Yes, thank you so
Yeah,
much.
no problem. I'm not sure. Ayo was asking something and I reply, but I'm not sure if she have any other question. Ayo, do you have any other question?
So just, you said we only start when there's symptom. So it doesn't matter any of the symptoms, whether it's shortness of breath or chest pain, but of course, patients would have one
Chest
or two
pain.
symptoms
No,
before
chest pain,
the
shortness
ECG.
of breath. 1 minute. Chest pain, shortness of breath. This is unstable. You will send him to the hospital.
All right.
Yeah, if the patient have chest pain, you will. Okay, that's no. You will not deal with him. You will not bring him
Via
to the.
emergency ambulance, you do? Via emergency
Yeah, that's
ambulance?
emergency. Yeah, without doubt, this is signs of
Via an
instability.
ambulance.
Yeah, without doubt. Okay, this sign of instability, and he might, when he come to the ED, he would, it depends for sure if it's heart, his heart rate, how much. But usually, if he have chest pain with AF, I will DC him. Okay, and if he have pulse, it will be synchronized. If he doesn't have pulse and are resting, it be asynchronized. Um, so chest pain is one of the instability signs of AF. Do we need to do blood tests? Because also that's something you might need to consider for that patient. Sophia, would you like to add for him some blood tests?
Yes, I think yes.
So what blood test you would like?
I
Well,
think we can
according to NICE, okay, just to be fair, according to NICE, no. But in real life, yes, okay. But you need at least to check his. Already they make for him renal function and the EGFR to calculate for sure the creatinine clearance and see what anticoagulation you will need. But
Yeah.
NICE they're saying no, but in real life, yes. What you will add plus the blood test that you already make? What you think?
TSH, like thyroid profile, TSH.
Yeah, you can add it, but the issue is if he doesn't have thyroid symptoms, I think clinically you could be guided by clinical vignette to add thyroid or not. But what
Full,
else? You
full
might
blood
need
count,
to.
isn't it? To check for
Well,
platelets and HP.
well, that's for the orbit score, and they make it. Already it's there. Yes, blood indices are normal, but there is other things that is very important. We need to check, and believe me, if you start to look at your patient and do this blood test, you will be surprised. And it's very important for any
Do we
cardiac
do
case.
magnesium?
Magnesium,
The
excellent. Who answer? Who answer is
Esther.
Esther,
Yeah.
excellent. Yeah, magnesium. Magnesium is a cardiac stabilizing agent, so it's very important. Okay, so don't underestimate magnesium. Unfortunately, the magnesium is underestimated in the GP land in the UK, but that's not right. Magnesium is very important. I saw people are dying from hypomagnesemia induced by PPI, and this is one of the drawback, okay, of the PPI, okay. That long-term PPI can cause hypomagnesemia, and that can cause fatal arrhythmias. One of the arrhythmias that can be caused is AF. So you need to check the magnesium, and usually you need to also to target level the magnesium to 1, okay, 1 during the treatment of the AF, just to stabilize the heart. So at least magnesium do, at least, okay? What else I want to ask? Shall we look at anyone have any other question?
Yes, I've got one
Yes.
question, please.
Yeah, sure.
So what I gathered from the notes that it's been an ongoing issue for a while, and it was picked up from before, but the patient, I'm not sure if we need to verbalize and open up to the patient about it, or just like leave it, or just mention that we need to look into what happened 12 months ago and why this wasn't addressed then. Do we need to open?
No, don't well, because well, I don't think so. You need to open it at that, at this instance now, okay? Because
Yeah.
mistakes can happen, and you cannot be 100% sure, to be honest, if he was having AF at that time or not. Yeah, he have some, maybe sinus tachycardia. How, provide that this patient doesn't have AF, by the way, he have flutter. So,
Yes.
and by the way, flutter, usually this is the other thing that I need to add it for you, but also not the sake for the exam. Flutter, when you have patient have flutter, refer him to cardiology. Yeah, start treatment, start BB blockers, start, and usually I'm beginning with the beta blockers rather than calcium channel blockers, especially the beta blockers that is approved in heart failure. So bisoprolol, metoprolol, carvedilol, these will be my first choices rather than starting him in calcium channel blocker, just in case, okay, if the patient will start to have any heart failure, I will not be blamed that because of the tablets that I started. And usually I don't feel also very, the guidance is saying don't do for everyone echo, and treating the patient blindly is one of the things that I don't, I'm not happy with. That's why I'm always running to the safe side, to the beta blockers that it's used in the heart failure, just in case. Is that clear?
Yes, thank you.
Yeah, no, remind me by your question because I feel that I didn't answer
No,
you
I was
properly. Yeah,
no, I was
sorry.
just like it's if it's like it's going to take a box for fitness or for practice or something like that. So do we need to like say
You can open up with him based on the fact that you have these symptoms going for a long time, probably from a year. Okay, you can tell him like that. Okay, so restoring your heart rhythm to normal, it will not be that effective usually. Okay, and that's it. So you mention it without pushing him to complain. Okay, because it's not a frank complaint. If this is a frank medical mistake, you need to open up with the patient. Okay.
yes,
Yeah. If there's a clear harm happen, you need to open up and to apologize. But here
sure,
it's debatable, isn't it?
sure.
The other thing that I was saying, flutter. So flutter is paroxysmal AF and flutter is one of the things that I will not wait. I will refer the patient to the cardiology because flutter usually responding poorly to the medication and will respond very good to the ablation and the cardioversion. Okay, and usually the long-term flutter will be transferred later on to fibrillation, so better to try to catch it early and transfer it to the sinus rhythm before the fibrosis happen to the atrium. So and always flutter prognosis is better than fibrillation, so you can send him to the cardiology and see what they will say.
Great.
Yeah. Let's any other question before opening because still there is PowerPoint. Yeah, so Sophia, go ahead. You
Can
have
we explain
question?
like atrial flutter and atrial fibrillation in the same way? How do we?
Can we what? Sorry, can you again?
How do you explain atrial flutter to the patient?
How you will explain flutter? Same way.
Yeah.
Irregular. Yeah, you
Same
can
way. Okay.
because this one is with variable block. So you will tell him irregular heartbeat. It's the same. It doesn't matter a lot for the patient, to be honest. Okay, but it matters for you for the treatment plan. But if it's
And
regular,
then refer to cardiology.
the flutter you need to refer him to cardiology. Yes. Okay. The only way that might make your explanation wrong if it came to you, flutter with the regular heartbeat, and this is the difficult one. And to be honest, this is one of the things that pushed me to do this. This this lecture, that you might miss patient with having ultra flutter with normal with regular heart rate, and then this will be a big mistake because you need to put him again, even if it's having regular heart rate but he have a flutter wave, you need to put him in anticoagulation. Okay, and missing it, you might put the patient at a risk of having a stroke. Sophia, are you putting your hand up, or this is all the question?
No, that's fine. Thank you.
Yeah, no problem.
Thank you so much.
Yeah, no problem. So we can, so I will come to this bit after we go through the management of the AF. So let me just see. Yeah. So one of the things also we need to refer patient to the emergency if you have a slow AF. So if you have irregular heartbeat and if it's clearly for your AF and the AF is less than 60, this is one of the things that you need to refer him as an emergency, okay? Because usually he will have an underlying disease, like severe hypothermia or digitalis toxicity or overdose of some medication. Okay, so don't risk it and treat it at the GP land. If the patient that you give him beta blocker and his symptoms become worse, okay, also please refer him to cardiology because he might have an accessory pathway, okay? And one of the things that it's very dangerous if you have Wolff-Parkinson-White syndrome, because if you keep giving beta blocker, you will put him in a VTAC or VF. No need for details, okay, for the sake of the exam or even in the real life. If he is worsening with beta blocker, send him back to the hospital doctor, okay? And we might in the future, make lecture about Wolff-Parkinson-White syndrome and more advanced cases in AF. If you feel that you will need, just write in the WhatsApp group and I will do it. Okay, and this is the definition of the valvular and non-valvular, okay, which is moderate to severe mitral stenosis and mechanical valve, and hearing to the chest, to the heart of the patient will be enough to diagnose that. Well, what is the importance of diagnosis AF or stroke and heart failure? And this is the Q risk 3, and you can see one of the things there is AF. So please, if you can do, Q risk 3 online for patient with newly diagnosed AF, that will be very helpful. And you will be surprised that there is a lot of other people. So patient with COPD having PRED for long term or something that will change their Q risk. You can see here also patient with migraine, okay, that will change his Q risk. So yeah, if you can use Q risk 3, that will be helpful for a lot of patients, okay. We already explained that, yeah, how to think about, for you, and yeah, we explained that. Yeah, this is here important. Why? I'm not sure if you remember, doctors, that we have an era that everyone wants to take omega-3. Okay, saying omega-3 is very good for the liver, omega-3 is good for the vessels, the omega-3, and everyone started to take tablet of omega-3. Unfortunately, one of the things that's connected to AF induction is omega-3 and treatment of hypertriglyceridemia. So every patient on treatment of triglyceride, okay, and he started to have AF, you need to stop the treatment of triglyceride. These are the risk factor, the modifiable risk factor, and this is the omega-3 tablets, okay, that we need to stop them if they have AF. This is a summary of the management of the AF, and here is the indication, because Sophia was asking about what are the indication of the echo. So structure or functional heart disease. So if you have heart failure or if you hear any murmurs, or if the cardioversion is planned. But to be honest, usually if the cardioversion is planned, they will do transesophageal echo, not transthoracic. So transesophageal echo is more accurate in diagnosis of intraatrial thrombus. And then if the orbit score is very high, they might consider that. What is also important in the annual review, so patients, when the patient come to you, okay, and he is having, AF, what are the things that you need to, to review it on yearly basis? For sure, the renal function, liver function, okay, the weight, okay, because it depends, on the weight you are calculating the EGFR, okay. Don't use the EGFR that it's calculated in the lab, okay. Please take care of that. Don't use the one that is calculated in the lab. Use the one that you can calculate it in System 1 or EMIS. Does anyone know where they can find the calculator?
Is it the one for the creatinine clearance?
Yeah.
On EMIS. Yes,
yeah.
on EMIS. There's a template on EMIS.
Yeah, so in the clinical, you will
or you
find
can download MD Calc. on your phone and then you use it and
the problem then you need to take the weight of the patient, on your phone. But if the weight was you already put it in the system, then the medical calculator will calculate it with EMIS, or system one directly without needing to take any patient information. So better use the system, okay, but don't use the AGFR estimated by the lab. And if you are using EMIS, you need to search about it, okay, with the Cook-Croft formula. But in system one, it's already there in the clinical, the tabs up, you will find clinical calculators. So you will just press on it and you will find it in the clinical calculators. Okay, but in EMIS, you need to search it, okay? Because according to it, you will see if you need to modify the dose of the drug or not. Okay, that's why it's important. And the weight of the patient will change from year to year, and it depends on the weight of the patient, the calculation. The other thing also, every year do the CHA2DS2-VASc and do the orbit score system. Okay. And these are the CHA2DS2-VASc and the orbit score. What I need to say here, so you can see here, if you remove the sex, okay, of the patient, and you calculate, so ignore the sex, because usually the female or male, if the female need 2, so already the sex, so if the patient have any cardiovascular risk factor, that will put him in the category of having anticoagulation. Okay, hypertension, congestive heart failure, diabetes, or stroke, or vascular, which all are cardiovascular risk factor. So just to make the things easier in the exam, okay? What we need to know here, orbit score system. Yeah, so here, this is what I told you. So orbit score system is used for understanding the modifiable risk factor. And then don't forget, having, alcohol, antiplatelet, non-steroidal, selective serotonin, or anemia. Yeah, who wants to ask? Sophia? Someone want to ask? Yeah.
Yeah, if someone is on antiplatelets and they have got AF.
Yeah, it's coming. Yeah, it's coming.
Okay.
Yeah, you can use that. No, okay, tell the question. No problem. Yeah, you can
If
use.
someone Okay, I mean, like if someone is on antiplatelets and we need to start anticoagulation, then what do we do?
Nothing, you started. Well, yeah, you will not stop the antiplatelet, and for sure, depending on the cause of why you are using the antiplatelet. For example, if that patient have peripheral vascular disease and he's in clopidogrel, you will just add the anticoagulation. If the patient, especially if the patient have MI, for example, and he's taking PCI, you will use the aspirin. You will use, you will use the antiplatelet. If the patient have a stroke, okay, and AF, okay, what you will do, you will put them in both, okay, and usually we start the anticoagulation first, and then after it, by 2 or 3 weeks, we can start the antiplatelet for the stroke. Okay.
Okay.
Yeah, you can keep it on them. And actually, someone want to say something?
Yeah, sorry for cutting you short. In that light as well, if someone is on bisoprolol and now got AF, what do we do? Do we?
If patient have bisoprolol and he's getting AF on it, and he need to control the rate, and the bisoprolol is maximum.
Yes, if the bisoprolol is maximum.
Yeah, my advice to you is to refer him to cardiology, because you will need to add verapamil or diltiazem. Okay, and it's very risky to add the verapamil and diltiazem without guidance from echo. Okay.
All right.
So I will strongly advise you to refer him to cardiology. Okay. In the hospital, we used to, in the emergency setting, we used to give metoprolol, and then if it's not responding and still rapid AF, I will give him verapamil. But the issue is, I'm in the hospital, so if the patient have heart failure, I know what I will do with him. Okay, because AF heart failure means that he wanted to DC. So what you will do if you start him on the Verapamil or diltiazem and he started to have heart failure with you, you won't be able to do anything. So better refer when you reach maximum dose of beta blockers and the patient is still having the symptoms, refer him. Or if he have the AF on already started beta blocker for hypertension, for example, refer him. Okay, don't take the risk. Is that fine, or you still have a question, or?
Yeah. Yeah. It's clear. Thank you so much.
Yeah, no problem, no problem, no problem. Here, rate control or rhythm control. Okay, and we'll mostly discuss all of that. And the digoxin and the amiodarone. Yeah, if the patient also have paroxysmal AF, refer him. Okay, because the problem is in the strategy of the rhythm control. Okay, as they will do, pill in the pocket, or they will give him long-term treatments. So also it depends on the experience of the cardiology, and then and the flecainide have a lot of problems, especially if you have structural heart disease. Okay, so better to avoid any complication, refer him. Don't interfere in these cases. Okay. Here, this just I put this slide because of this, the ejection fraction less than. So usually I'm running for the beta blocker that is approved in the heart failure, because according to the guidance we don't need to do echo routinely. So I would go for these for these three before putting anything else. Okay. So I put this slide for the anticoagulation because also from the things that NICE recommending is any patient on warfarin, in the annual review you need to discuss with him transferring the warfarin, or changing the warfarin to DUAC. Okay, that's if there is no definite indication of warfarin. So normal AF, not valvular, not mechanical, and he doesn't have resistance to to the new oral anticoagulation, then you can transfer him to the NOAC when his INR is 2 or less than 2. Okay, that's all this slide because of that. Okay. Did anyone manage to try to change the patient from warfarin to NOAC? Anyone here have experience in this?
Yes, I've just done that recently with one of the patients.
Good. Well done.
An elderly patient. He's got atrial stenosis, so it wasn't actually a valvular AF.
Okay.
By definition. So yeah, just for convenience sake, because he's been on warfarin for ages for no reason. So he's coming every week for his INR.
Yeah, you are right, and this is a big issue. Every weekly INR or monthly or 3 monthly, and then restriction of food. Don't eat fruit, vegetables. Don't eat greeny things. Don't eat. It's a big hassle, to be honest. But the issue is still warfarin have its own indication. Still, if you have atrial myxoma, if you have valvular problem, okay, if you have resistant, because the issue is, I saw cases that have rivaroxaban resistant, and they even get PE or DVT over it. So if you start to look at this patient, you will find there is some, they are not a lot, but the new oral anticoagulant resistant is there and present. Okay, so still the warfarin have its own indication in these cases. Okay.
How would you know if they are resistant to it unless they try?
No, they try and they have PE on it. Yeah, you're right. And that's one of the things that always you need to think about it. If you have a patient, for example, using new oral anticoagulation and he's coming with leg swelling, okay, does this patient have resistant, or this is DVT or not? Is very difficult. Okay, very difficult. But it's there, and you need to have high, suspicion. And then if your clinical suspicion is there, don't omit the fact that you are a doctor and you have your own clinical suspicion. Having patient on the anticoagulation, especially NOAC, doesn't mean that he will not get a PE. Doesn't mean that he will not get a DVT, because the resistance is there. Okay, so be cautious about that.
Yeah.
Other thing, for example, patient approved to take anticoagulation, and then he, and the trick was in the case that he like the anticoagulation to be once a day. So he doesn't want to take twice a day, So you will have the endoxaban and rivaroxaban. These are can taking once a day. Apixaban, the bigatran, can be taken twice. Okay. Additional to the EGFR that control, the dosing, so apixaban have two other additional things, which is the age and the creatinine. So, which called the ABC scoring system for apixaban. So if the age is more than 80, the body weight less than 60, and then the creatinine is more than 133, or 1, if by milligram is 1.5. But if by the UK numbers is 100, I think 33. Okay, so the 5 milligram twice daily will be 2.5 milligram twice daily. Okay. Then, and this slide, I bring it for one thing. So you can see that all of the oral anticoagulation having a renal modification when the EGFR decreased. Okay. The only one that also you need to be cautious about it, if the patient have super normal or high normal EGFR, is the endoxaban. So if the EGFR more than 95, the efficacy of the endoxaban will decrease, and that's, you need to be cautious about it. Okay. Because the creatinine, the clearance of the drug from the bloodstream is equally divided between the liver and the kidneys. Okay, the others, one of them will have the upper hand, but here is 50-50 chance, and that's why if the EGFR is very high for the patient, then you need to be cautious. Don't take it as a first choice. Start any one of the others. The other thing, rivaroxaban, I saw a lot of people getting intracranial bleed from it. It was out of fashion for a few years ago until the last year. I think because of cost issues, the rivaroxaban started to take again one of the upper hands there. So you might consider starting the patient on it as well. Most of these we say it, and this is the rate control, near onset 48 hours. Yeah, the only time that you would consider stopping the anticoagulation, okay, is if the patient have left atrial appendage occlusion. Other than that, if you have, even if he did the cardiac ablation, then he will still be on anticoagulation. Okay, the other time would be also, you might consider stopping it if the patient have pacemaker, because the last step for controlling AF, is putting an pacemaker. The patient can have either rapid pacing. Okay, you can put a pacemaker to control the heart rate, and then you might consider stopping the anticoagulation at this situation. Okay, modifiable risk factor, and this we said about the risk of. And this slide for the antiplatelet and the anticoagulation, and I think I explain it. Does anyone have any question regarding the antiplatelet and the anticoagulation? Because it's important. You will find it in real life. Keeping in mind now, some of the STEMIs and non-STEMIs, we are putting them on double antiplatelet and also anticoagulation, namely the rivaroxaban. So you might find people having double antiplatelet plus one anticoagulation. So don't be surprised, okay? Because it's one of the modalities of a trinity non-STEMI, okay? Yeah, and this is slide for the non-rate limiting and rate limiting calcium channel blocker and beta blocker. Okay.
I've got a question, Salim, please.
Yeah, sure. Yeah.
So you said usually we start the anticoagulant before the antiplatelet, 2 weeks after.
This is in the AF. This is in the stroke.
But what about for patients who are already on antiplatelets?
No, 1 minute. This is in the stroke. When I was talking about the stroke. No, again, what the patient already in antiplatelet and you want to put him in anticoagulation.
Yes.
Yeah, you can.
Okay.
You can, provide that you optimize the bleeding risk. Yeah, you can.
Okay.
Yeah. So especially if so if the patient having peripheral vascular disease or if he having, stroke or that, you can put both of them. And even if the patient having anticoagulant and having peripheral vascular disease, you will put antiplatelet. So you can. Okay. After discussing for sure the bleeding risk with the patient. Okay.
Okay.
Sorry, can I ask
Yeah.
about the bisoprolol? A patient that was previously on it, maybe for heart disease, and now develops AF. Say patient was actually on maybe low dose 2.5. Do you need to max the dose before referring?
Maximize it for sure. Maximize it. Reach the 10 milligram. Yeah. Maximize it. Maybe when you maximize it, the things will be controlled. Yeah, maximize it. The problem is if you reach the maximum, this is the problem because you don't know what you will do next. Well, if you want to take the risk and start him in verapamil, it's up to you, okay? But I don't advise. Better leave it for the cardiology, or even have a letter from them and see what they will say. If they said, okay, try, discuss with the patient, tell him the risk, and try and start it. Okay. Yeah. Although it's one of the indication of referring to cardiology, he cannot refuse your referral. Okay, but the issue is until he see the patient 2 weeks or 3 weeks or 4 weeks with with the unpleasant symptoms of AF, it is little bit harsh to on the patient. And this is the driving restriction. Okay. Anyone have question in these driving restrictions? No. No. Okay, so what if the patient started to bleed in the anticoagulation? Where you will manage him? If patient have apixaban or rivaroxaban and he's coming with bruises of his hand or bruises of his arm and little bit of gum bleeding, little bit of epistaxis, how you would manage him in the GP land? Would you refer? Would you treat? Anyone knows, doctors? Anyone want to participate?
I think we hold apixaban for a few days, isn't it?
Yeah, you're right. So if it's mild bleeding, you might consider holding the anticoagulation and see how the things will go. If for sure, if it's massive bleed or moderate bleed, refer the patient and we have the antidote. Okay. The antidote of the Bigatran is cheap, but for the other three is very expensive, and 10,000 I think is the injection. So yeah, so there is some restriction in how where, when, and how to use it. Okay. Yeah. So here. So Adurasumab is injectable. Okay, I think 5 milligrams. Or 5 grams, and it's not that expensive. But Andoxan Alpha is the one for the apixaban, rivaroxaban, and the others is very expensive, very, very expensive, and need the hematology consultant to sign the paper to start it. And that's the algorithm of the bleeding. So if it appears, usually it will appear mild bleed, so you can hold the anticoagulation and then reassess. If it's more than that, just refer. Don't wait. Okay. I hope it was clear. I'm open for any questioning at this point. Let me just see. Does anyone have question? Do you want me to go through the ECG of AF and the flutter? Because there was some.
Please.
Yeah, you want? Okay. So let's bring it from the start.
if someone comes to you in surgery for some other reason and they have got a high heart rate, say 130, and you do their ECG, and it shows AF, but you don't know when did it start. I mean, like,
well, no, you know, because if he is 130 and he doesn't have symptoms, this is a chronic.
okay.
You know, 130 is, you know, is a lot. Okay, and if he doesn't feel that his heart is racing, then this is a chronic. He used to that.
Okay.
Acute, he will come and tell you, I have heart, you know, I have palpitation. So, and if you are in doubt, it's always chronic. Okay, don't take the risk and DC him. Okay, and you need to know, the more the patient is on AF, the less likely the DC will work for him, because his heart will be full of fibrous tissue. All of that will be fibrous tissue. So even if you do DC cardioversion or even chemical cardioversion, he will not respond. Like here, you know, 5 minutes he will return to sinus, the other 5 minutes he will return to the AF. Okay, and then you will put him in the risk. When you return him to the sinus, you will put him in the risk of stroke. That's why don't risk it. Okay, if you are in doubt, give him the anticoagulation 3 weeks, and then during these 3 weeks do the referral and let the cardiology decide. Okay, because also the cardiology will not decide because he's having experience. No, he will do the echo, will usually transesophageal echo and see if there is a clot there or no. Because the problem, the left atrial appendage, okay, is very in the back of the heart. So when you are doing echo, it's very difficult to appear. So if there is a clot inside it, the only way is to come from the back of the heart. Again, if you can see in this, you know, here in this, you know, in this photo, we usually are putting the probe of the echo here, okay, and the left atrial appendage is in this area with an angle. So it's very difficult to see what is in the appendage. It's like a hole here, you know, with only transesophageal, with the transthoracic echo. The only way is to be 100% sure that there is no clots and the heart is coming from the back. So if you have, you know, if you can imagine, so the esophagus is just behind the heart. So you will come from the back of the heart because it's like endoscopy. So transesophageal echo is exactly like the endoscopy. You will put the probe, go behind the heart here, and then you will have direct look of the appendage. Okay, there is no clot, so well and good. We'll DCU or cardiovert you chemically. If there is a clot, we will continue on the anticoagulation for another few weeks and reassess if there is a clot or not. Okay. So what are the main difference between the flutter and the fibrillation? So the fibrillation, you will have multiple sources of ectopy, multiple sources of firing. Okay, that's why the heart will be chaotic, okay, and irregular. But in the atrial flutter, you will have a circuit, okay, and that will make the heart more regular. The irregularity will come from the AV node. So if the AV node is blocking in different, you know, in different interval, then your heart rate will become, you know, irregular. If the AV node is blocking at regular interval, then the heart rate will be, you know, will be regular. The other question, so this is a short circuit. Short circuit means that the circuit is in the atrium, so it will cause the flutter. So if this patient have long circuit, which taking the AV node like this and then coming back here, taking also the ventricle, what it will give? Anyone you know? What it will give you in the ECG? These are extra information. It's not important. It's not important for the exam purposes. So the flutter is short circuit. What are the other rhythm if we have long circuit? How it will come? What the patient will present with? Is Dr. Ahmed here? Or no? No? So usually it presents with supraventricular tachycardia. Okay. Coming to the flutter and how the flutter can present. Just a few examples and then we will conclude. I know all of you become tired. So here, this is the differential, okay, between regular and irregular, narrow complex tachycardia and broad complex tachycardia. And I said if it's regular, so it's sinus, flutter, or SVT, or irregular is MAT or flutter with variable block or AFib. And then we said that the sawtooth appearance is one of the characteristic of the flutter. Okay, and the flutter can come, the heart rate can come according to the AV block. Okay, if it's 1:1, it will be 100. 2:1, it will be 150, because usually the flutter is 300. So according to the variability of the block, it can be half of it is 1:2, or 100 means 3:1, or 4:1 is 75. And all of this, even if it's regular, you need to treat him as AF. Like you need anticoagulation, Chad-Vasky score, and orbit score. So that's one of the example. This is a very difficult example, but in general, if you find a heart rate of a patient around 150, so you need to consider flutter, okay? And if you enlarge this ECG, you will find some of the flutter waves here. You can see here B, okay? And then if you make another large square, you will find like B here, if another large square, B here, another large square, B here. So if you search for it, you will find it, okay? So any ECG with a heart rate 150, consider it flutter till prove otherwise, and search for the extra B waves, okay? This 4:1, I think 4:1 was 75, okay? Heart rate 75, it's easy. You can find here B wave, B wave, yeah, B wave, B wave. So it's not difficult to diagnose. Fibrillation, okay, you will not find a definite B wave, okay? You will find fibrillatory B waves, which are very small, okay? You can see here, small, 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 very small B wave. It will not even be more than one small square, okay? But the flutter, you can see the B wave is well formed, you can see, very big, well formed. But in fibrillation is very small. It will not reach one small square. Yeah, that's mainly what I wanted to say. But in the future, okay, after all of you finish the exam, we can go through what is Wolff-Parkinson-White syndrome, okay, and how you can differentiate WBW with the AF and the flutter, and what is the drawback of that, okay? Anyone have question, doctors? No?
I
Thank
have
you
one
so much.
silly question, please.
Yeah, well, go ahead.
At what blood pressure we can't start beta blocker?
At what blood pressure you cannot start beta blocker?
Yeah.
Well, to be honest, there is no specificity for that, to be honest. But if the patient is unstable, okay, so usually if the patient, the systolic 90/60, for sure you will know that's unstable. So I would say from 110, over 70, I would, below it, I will not start, the beta blocker. Above it, I will start beta blocker. Okay.
Thank you so much.
Yeah, no problem. Anything else? No? No other question? Shall I stop the recording? Okay.